I think I will get started. Hello, everyone, and welcome to Let's Talk, Conversations about Women's Health. I'm Dr. Judy Regensteiner, and I welcome you to this presentation tonight, which in honor of February being Heart Month is entitled Mending a Broken Heart, Technologies, Treatments, and Threats. Since we're unable to meet in person, which is certainly my preference, but I'm so glad we can meet in some way, we're delighted to bring you this program virtually. With women historically excluded from research studies, there are many unanswered questions. The Center for Women's Health Research studies women's health and sex and gender differences, particularly in the areas of cardiovascular disease, diabetes, and the intersections of mental and physical health. The center is committed to a future in which research includes women and men and accounts for sex and gender differences. We do this to shape better health care for all. We do this through research, by mentoring and training, and through educational events. Let's Talk is 10 years old. It was created 10 years old by the center in partnership with UC Health to educate the community about health through evidence-based talks. Each talk is uniquely created and presented by nationally renowned experts. This evening, we'll be focusing again on cardiovascular health. We have a fantastic speaker line. We have Dr. Dave Kao, Assistant Professor of Medicine and Cardiology, Dr. John Carroll, who's Professor of Medicine and Cardiology, and Dr. Kylie Adamek, Instructor of Medicine, Hospital Medicine. Please type any questions you may have for the speakers into the Q&A window. At the very end, after the three talks, we'll have a moderated Q&A session. Tonight's program is being recorded. Recordings of past events and additional resources can be found at www.cwhr.org. We will be sending out an evaluation after the talk. These evaluations are very important to us as we take your feedback very seriously. We're always looking for ideas for additional programs, and hearing your thoughts is of great interest to us. Please mark your calendars for our next program on April 28th, which will focus on infectious diseases. Finally, if you're a healthcare provider, here's a plug for one of our upcoming program, which is our symposium on women's health on February 27th, which is a CME program, and you can register at cwhr.org. So I will now introduce our first speaker, Dr. Dave Kao, who, as I mentioned, is Assistant Professor of Medicine and Cardiology. He's the medical director for the Colorado Center for Personalized Medicine and a general cardiology physician scientist who focuses on heart failure. He studied biomedical engineering and graduated from medical school at Johns Hopkins, and then completed his internal medicine residency and chief residency at Stanford University. His research interests are in sex differences in cardiovascular disease and personalization of heart failure management based on medical conditions, as well as demographics, social factors, and genetics. The title of Dr. Kao's talk is Precision Medicine and Clinical Practice. Where are we and where are we going? Dr. Kao.
Thanks, Judy. Let me just pull everything up here. And can everybody see my slides? Okay, excellent. So today I'm going to talk a little bit about precision medicine, and I'll define that in a second. I'll preface this by saying most of the talk is about heart failure. I did include some stuff about COVID just because it's so timely and illustrates some important points. So I'll divert from the heart a little bit, but I think it's worth it. So I'm going to go through a few clinical examples just to ground the discussion. It can get a little abstract otherwise. Compare precision or personalized medicine versus what we typically do now with guidelines and evidence-based medicine. We'll talk about some of the things that go into personalized medicine strategies and how we figure that out, ongoing challenges, and then where we hope to get in the future, in particular here at UC Health. Okay, so I'll start with the example of COVID. There's some things I'm sure you heard in the news that are related to this idea of personalization of care. I'm sure you've heard that there are high-risk populations, obese folks, non-white patients, the elderly, nursing home patients, and so on. Among all of those, there's some people who have no symptoms at all, and other people get terribly ill or pass away. There are all manner of complications, lung, blood, heart, brain, but we don't really know who gets what and how to figure that out. You've heard something about our treatment options, which I think have been touted more by politicians than their efficacy is in reality. But they do work for some people. Some people really are going to probably succumb to the disease no matter what we do. Who are those people and what should we do about them? And as I know everyone has heard, we have limited resources in terms of treatment, beds, staff, PPE, the whole thing. All that is to say that understanding that individual variation in course of illness and response to treatment would be really, really valuable given our resource limitations and the incredibly wide spectrum of disease that we've seen. In the case of heart failure, just a quick definition. So heart failure is defined as the inability of the heart to pump enough blood around to meet the body's needs, or the ability to do so only with symptoms of fluid buildup in the body. So that's stuff like shortness of breath, swelling in the legs, and so on. Diagnosis of heart failure is a pretty grim prognosis. About half of people are dead within 5 years. There are a couple of broad flavors which are important for this discussion. You can break them into one half that has a weak muscle and one half that has sort of a stiff muscle that doesn't relax the way that it needs to pump effectively. Of the folks with a weak heart muscle, most are men, and there are many medications and devices that have been shown to improve survival. Of the other kind, those are 70% women. There are no consensus-proved medications that improve outcomes like survival and hospitalization, although there's one candidate right now being considered for FDA approval for this. It has not been approved yet, but it's the closest that we have. I think it's safe to say, though, that the female predominant form of heart failure has far fewer treatment options than the male predominant. Just to give an example of why treating everyone the same way may not make sense. So I have 3 examples here. The first is a young woman who develops severe heart failure shortly after giving birth. The second is a young man with a family history of heart failure who sort of abruptly gets sick with no other apparent reason. And then the third is an older man with a bunch of medical problems who kind of slowly gets worse and worse over the years. So as you might imagine, just looking at these descriptions, they're all quite different. They probably have different reasons that their heart isn't working right. And yet they're all treated with the exact same medications based on the guidelines that we have. The idea of precision medicine is to say, well, maybe one thing works particularly well for one of these folks, and they really only need that drug, or nothing is going to work for them, and you need to think about transplant evaluation, something like that. Bottom line is they probably don't necessarily respond equally to the same things. So in terms of precision medicine versus how we do it, you've probably gotten the flavor of it so far. Where in precision medicine, we're trying to tailor management to the individual characteristics of each person, with the underlying assumption that everybody, or not all patients, respond the same way to the same things, nor is the course of their disease the same. Right now, we have large clinical trials, which I'm sure you've heard of, that test treatments in a large variety of people. And if say a medication appears to work in that large variety of people, it becomes a guideline, and everybody then gets that medication, even if it doesn't work for some people. That's the gold standard right now. Precision medicine is an emerging approach where we're really trying to learn how to take into account lots of things like demographics, other diseases, your genetics, where do you live, what do you do, what are your relationships like. All those things can play into health, how you take medications, what sorts of strategies work for you. So that's kind of the underlying thinking behind precision medicine. This is just a picture that kind of represents that. So on the left, you have a large population with a bunch of different types of folks. They're represented by the colors. The standard approach in the upper right, kind of you treat everybody the same. About, let's say 20% respond to the treatment and the other 80% don't and may have side effects. On the bottom, you can see they're lined up where the populations are sort of separated out, and each one has their own treatment that works most of the time. So you don't have as many people being exposed to the treatment unnecessarily, resulting in cost and an increased risk of side effects. When people talk about precision medicine, especially in the academic setting, they often think of genomic medicine or genetic medicine. And while genetics are an important part of it, I feel the need, maybe because this is my own personal work, that you can personalize medicine without genetics. And in fact, we've been doing that for the entire history of medicine. So I think we can be better at that. And we are trying to develop more robust ways of doing it. Genetics, I think, will end up just being a part of that. So how do you do it? Well, as we talked about, the idea is that there are smaller populations of patients within large disease groups like heart failure. In order to study those smaller populations, you just need a lot of heart failure patients, which in the past haven't really existed, but patient groups that size have not been easily studied. You also need lots of different information in order to identify those groups, because those subpopulations may be defined by a bunch of different things. So we look in electronic health records, census data, for example. Where do you live? What are your genes? What are your habits? Wearable devices are certainly becoming a part of this. Measurements at home, for example, blood sugar, blood pressure, and other things. And we try to mix all that together, use fancy machine learning and artificial intelligence methods to come up with some kind of insight and recommendations. One of the important things that we try to keep in mind is that the data needs to be available both to you as a patient or a person and your doctor or providers in order to make best use of it. And I would argue that the patient is the one who can really make the best use of all this stuff. These are just some illustrations of the things that I mentioned on the left. We have some items from the electronic health record, specifically medications and labs. On the bottom, you have like an ancestry, like an ancestry.com sort of readout of your ethnic background, which can affect your predisposition to diseases. On the top is a fun app that tracks your mood. So you can see how your mood sort of behaves over time with different events. And of course, the Fitbit display on the right. So these are all elements that can go into a precision medicine sort of analysis in order to try and figure out what's the most important stuff. One of the reasons we can do this is because we have more patients, as I mentioned earlier, than we could before. Historically, maybe we could get to 20,000 patients in a single analysis. That was really a lot. If you combined a bunch of studies, you could maybe get up to 100,000-ish. But now our modern warehouses are much, much larger than that. At UC Health, we have 6 million patients alone in our electronic health record, and we can analyze most of their medical data. There are countries in the world who've genotyped or gotten full genetic sequence for over half of their entire population, like Iceland. They have national health records because of their health system. So those sorts of settings make it easier to really define what is contributing to certain kinds of diseases, especially because it's relatively homogeneous in terms of race. And then finally, data networks. These are relatively new in terms of how robust they are. But for example, we can share data with, I think it's 40 countries around the world from our EHR and analyze it all in the same way. You can look at all kinds of different things, including the social, cultural, economic, technologic variations across all that space. So then once you kind of assemble all that, you're really trying to develop knowledge about what is the most important thing. And I've mentioned a lot of these factors already, so I won't list through them again, but suffice it to say that we're really just trying to understand how best to understand people. Once we do that, we want to see what works best for them, whether it's by looking in clinical trials or watching in electronic health records as to how people do. But ultimately, we want to figure out ways to decide what treatments to use. A simple, really simple way to think about this is you have type 1 diabetes, the kind you get as a child where you don't make enough insulin, and type 2 diabetes that you get as an adult where your body doesn't react as well to insulin. Clearly, the treatments for those two are different. Type 1, you have to use insulin and the other medications don't work. Type 2, you often don't need to use insulin at all and use different medications. So that's kind of a rough example of a disease, diabetes, that you personalized treatment to based on the underlying conditions. We really hope that these can lead to tools that allow us to share decision-making between patients and providers to pick the things that work best for everybody. This is an example of a way you can actually predict or understand what interventions are going to improve your survival visually, so you can change around medications and what you're on and see that your survival might improve from 32% at 5 years to 65% at 5 years, so double based on starting certain medications and having a device put in this form of heart failure. This one is a way of predicting complications of surgery. So if you're trying to decide, should I have my colon removed for this mass, you can put in a bunch of different features and then understand what your likelihood is of each kind of complication. I use this a lot when kind of deciding with patients whether they want to go through with things based on how likely they are to have certain problems. I'm usually focusing on the cardiac complication piece of it. So there are times when people just decide the risk of the procedure is not worth it in terms of the likelihood of their disability afterwards. So this is another example of a procedure-specific and person-specific estimate of the risks around something in order to help decide whether you want to go through with it or not, and then if you do, how to plan for it the best on the other side. Beyond just simple prediction, like we were talking about, how do you kind of make these profiles of patients or try to find subpopulations? In this case, you can use a type of machine learning or artificial intelligence to take groups of variables and look for patterns. And that's basically what is happening here with a certain kind of heart failure, the kind where the heart is stiff rather than weak. If you throw all these 11 variables into one of those machine learning algorithms, it comes out with these patterns that I roughly sort of associated with Simpsons characters, ranging from kind of middle-aged men, kind of overweight, but not many health problems, younger women with no health problems, and then older women with everything. So these are profiles, right? There's not one thing that defines any of them. There's a whole bunch of stuff that defines each of them. It turns out that they have very different characteristics in the way that they show up. For example, the Marge character for this kind of heart failure tends to have a lot of symptoms, the most of any of them, surprisingly, but survives for quite a while, really doesn't have that many hospitalizations, is much less likely to die. She's just really driven by being short of breath a lot. In comparison, Abe Simpson here is pretty sick, but has no idea about anything really, and so really doesn't complain of any symptoms, despite the fact that he does have a lot of hospitalizations and does die relatively quickly. It's just a very different picture. He is actually sick. She has a good prognosis, but feels very sick. Here you can kind of see how they rank in terms of their survival. Higher is better. So you can see this is the Marge character is way up here. So at about 4 years, only about 10% have had a hospitalization or passed away, compared with Agnes Skinner here, 60% have died or passed away. So that's a really large difference in prognosis, and that's just based on kind of their profile and not any other prediction that we would do. We also want to look at and see who may respond to a treatment and not. In this clinical trial, there's no effect of the medication in the whole population, but the Barney character here actually did have an improvement in survival with the medication, whereas no one else did. So the point there being that, yes, indeed, maybe treatments do only work in some groups and not others. This is kind of a fun one, looking at the timing of being hospitalized for heart failure and what effect does that have. So in the upper left, you have mortality. So that's dying in the hospital versus the month where you came in. You can see January is in the gray, is clearly the highest by quite a lot. It's about 6.8% compared with May, which is about 5.4%. So that's like a 30% difference, something like that, which if you think about it is really enormous in terms of did I die or not when I came to the hospital. If you look at day of admission, Monday is the best, Friday is the worst. That's about a 20% difference. And then time of day of admission, 6 a.m. has the lowest mortality, about 4.1%. And 6 o'clock p.m. is the worst at about 6.5%. So again, that's about a 50% difference. Now they're actually pretty large differences in likelihood of making it out of the hospital. So in COVID-19, what we ended up doing was using artificial intelligence methods to try to predict who is likely to die, who is likely to end up in the ICU, who is likely to get off a ventilator if they went on one, who is likely to respond to treatments, who is likely to not, who is likely to pass away no matter what we did, who's likely to get long haul effects. And a lot of this was around the need to optimize A, management of patients, and B, the resources that we have. Fortunately, we didn't have to use this in a very aggressive way because the situation never got bad enough, but that's how we used these concepts with COVID. We've also been doing other things where we're looking at changes in gene expression, proteins, vaccine response, and all that. So challenges here, it's really around linking data and analyzing data and then interpreting the outcomes. So you need some expertise in managing big data, cloud-based computing, AI, and data science to make sense of all that. Ultimately, we do need to teach providers how to use it. And I think we're pretty close to that. So I know I'm just about out of time. I think all the points here I've already hit. So I am going to turn it back to Judy and Dr. Carroll, and I'm happy to answer any questions at the end.
Thank you, Dave. That was great. As the director of the Center for Women's Health Research, I always think it's important to mention the mission of the center, which is to do cutting edge research in women's health and sex differences in the areas of cardiovascular disease, diabetes, and mental health as it intersects with physical health, all of this across the lifespan. To educate and mentor, I would say, the next generation of scientists, male and female, MD and PhD, who will study women's health and sex differences, and to educate the public and their healthcare providers with evidence-based information so that everyone can treat their health in the best possible way. So I always want to tell people the mission of the center because it guides everything that we do. Our next speaker tonight is Dr. John Carroll, Professor of Medicine, Division of Cardiology. He is an interventional cardiologist and has been the Director of Interventional Cardiology and Co-Medical Director of the Cardiac and Vascular Center at UC Health and the University of Colorado Hospital since 1996. To say this is to understate his reputation. I remember being at a cardiology meeting a few years ago and going to O'Hare Airport to go home, and the whole group around me was talking about Dr. Carroll. And when they heard I was from Colorado, they just said, "Do you know Dr. Carroll?" I said, "Yes, I do." And you have an amazing, I don't want to say fan club, but a lot of very impressed people. Dr. Carroll's clinical and research interests are related to structural and valvular heart disease interventions and the development of advanced cardiac 3D imaging for image guidance. His talk tonight will be about treating narrowed or leaky heart valves without open heart surgery. Thank you very much, Dr. Carroll.
And thank you, Judy, for inviting me and your wonderful center and the work it does. And hello to all of you out there. I'm sorry we're not in the same room to have more interaction, but hopefully that will come soon. So the treatment of people with valve problems has dramatically changed in the last decade, and it really is accelerating. And that's what I'm going to focus on, but I'm going to give some background. And some of that I'm going to utilize some wonderful medical illustrations by a physician artist, Frank Netter, who no longer is with us, but grew up in New York City, wanted to become an artist. His parents said no, so he became a doctor, then he became an artist. So he's had a wonderful career, and I hope you appreciate some of the figures. So do you know anyone who's had heart procedure to repair or replace the valve that was not open heart surgery? Here's someone. Elizabeth Taylor had a MitraClip procedure for a leaky mitral valve. Arnold Schwarzenegger had his aortic valve replaced with a transcatheter approach. He was awake. Mick Jagger, just a year and a half ago, while in New York City, got a new aortic valve, and 6 weeks later, he was back dancing away. And that typifies the recovery time from these procedures. So let's talk about physiology, anatomy, and valve problems. So the heart is fundamentally a pump. It's got inflow, outflow. There are 4 heart chambers that the walls are muscles that contract. And it's a very sophisticated pump with a right and a left side. And it's a pulsatile pump, and it requires valves for its function. And the top figure shows these 2 valves, the mitral and the tricuspid valve. They're open while the pulmonic and aortic valves are closed. And then the heart muscle contracts, and these 2 valves open and these 2 valves close. So the normal function of the 4 heart valves is, first of all, they open and close from the pressure generated by the intermittent contraction of heart muscle. Secondly, the sequence of muscle contraction results in heart valves opening and closing in a highly coordinated fashion that keeps blood moving forward. Heart valves, when open, present little resistance to blood flow, and heart valves, when closed, prevent backward flow of blood. What about abnormal function? When a heart valve is closed, but it does not form a tight seal, backward flow occurs, the valve leaks, and we call that, for the mitral valve, regurgitation or insufficiency. When a heart valve is open, but the opening, or what we call the orifice, is smaller than expected, there is increased resistance to forward flow. An example is aortic valve stenosis. Those abnormalities produce a series of symptoms that have a range of severity and presence in different people. Progressive breathlessness, especially with exertion, is common. The retention of fluid in the form of edema and belly swelling from ascites occurs. And also, you can get chest heaviness with exertion, angina pectoris. Another symptom is sudden cardiac death, particularly with the valve disease, aortic stenosis. And on the right graph, you see people slowly develop aortic stenosis, but once symptoms start occurring, it has a prognosis that's worse than most forms of cancer. So it's a very serious disorder that needs to be treated in a timely fashion. There are a lot of different disease processes that can affect heart valves. Traditionally, I think many of you have heard about rheumatic fever, which fortunately is no longer a major public health problem in the US. It is elsewhere in the country, and it affects heart valves differently and somewhat by gender. Rheumatic aortic stenosis is more common in males. Rheumatic mitral stenosis is more common in females. Then there's the degenerative or calcific aortic stenosis. Then you can be born with an abnormal valve, and for the aortic valve, it's bicuspid. And down here, D, this is a normal valve, and look how nice and thin it is. It's in a closed position versus these other valves where there's thickening, calcified nodules, very abnormal valves. So one of the wonders of the therapeutic accomplishments has been the eradication of rheumatic fever. I think we all remember as a child having a strep throat or suspicion that it was, and boy, you got that shot of penicillin rather immediately because that prevented the post-infectious inflammatory response that occurred in some people, and it's called rheumatic fever, that damages heart valves significantly. But we've done away with rheumatic valve disease to a large part in many countries, but now we're seeing an upsurgence of heart valve disease that's related to aging, degenerative changes in heart valves. And we see here prevalence of moderate to severe valve disease versus different age groups, all valve disease, mitral valve disease, and aortic valve disease. And if you go even higher to over 80 years of age, you're talking about up to 1 out of 5 people having abnormal heart valves. So it's a major problem that's becoming even more so because we, as well as other countries in the US, are seeing a significant demographic shift. We're getting older. Why in the US we're particularly seeing this in the other countries is because right after World War II, the fertility rate just shot up. And I, and probably some of you out there, are part of this baby boomer generation, and we're hitting this age group where degenerative valve disease is unfortunately quite common. So how does a heart valve problem get diagnosed? How is it even suspected? Well, it really starts with a very traditional medical technique called auscultation, where you listen to the heart and you hear lub-dub being the normal, heart valves open, the sound of the closure and opening of heart valves, versus there's a whooshing, that's a heart murmur. And when your primary care hears that, they order an echo. And echocardiography or ultrasound of the heart has transformed the diagnosis and characterization of valvular heart disease. On the left panel, we see a mitral valve, 2 kind of doors, what we call leaflets, opening, closing, opening, closing. Here's the left ventricle pumping chamber, left atrium is up here. Color flow Doppler identifies red blood cells and what direction they're moving to. And this multicolored regurgitant jet is blood going backwards. That is, the mitral valve is not competent it's loose there. And so flow can go backwards, which is terrible. It increases pressure behind, it decreases forward flow to the body, so people feel fatigued. The normal aortic valve, we see nicely couple different directions. See how nice and thin, and this is a 3D. It opens up in most people to the size about a dime. When it narrows down, it's barely the dimension of the diameter of a pencil. That's severe aortic stenosis. So it's a mechanical problem. Fix it. You can't dissolve calcium from heart valves once it's embedded. You can't make them thin again. You've got to do something. And an amazing thing happened with the advent of open heart surgery. Professor Lillehei at the University of Minnesota is one of the early vanguards in this area. And this book, King of Hearts, is all about what happened back then. It's tough reading because it shows how disastrous the disease was. The initial patients had high mortality rates, and to operate on the heart, you have to stop it, open it up. And back then, there wasn't the technology to do that. So down here, one of the first people to have open heart surgery, they used the father to hook the child up to serve as the heart and lungs of the child, while Dr. Lillehei stopped the child's heart, opened the chest, stopped the heart, and repaired it. Fortunately, things have moved on since that, and we have here a cardiopulmonary bypass machine that allows the surgeon to stop the heart. It continues the pumping process, it oxygenates the blood. It's very effective, very safe, and one of our leading surgeons, Dr. Joseph Cleveland, is part of the heart team at the University of Colorado Hospital. This is one of the earliest mechanical valves. Starr Edwards, a physician, a surgeon, and an engineer are the names. And it opens, closed, and therefore serves as a valve. Many other mechanical valves have been developed, and also tissue valves, where it's a sewing ring, and this yellow tissue is the tissue from the pericardium of a pig. So there's a pig valve, not really a valve from a pig, but it's using the tissue from a pig's pericardium to create that. There's also cow valves using the pericardial tissue. Interestingly, I placed a valve in a Wyoming rancher that was used tissue from a cow. And what did he ask me? Did the tissue in my new valve come from a bull or a heifer? He wanted to know. And I said, well, I don't know. They don't tell us. It's not on the label of the valve. He said, well, what I'm going to do is I'm going to walk out in the field with my cows and see what happens. So, surgery for heart valve disease is highly developed. Why develop an alternative? Well, increasing prevalence of valve problems as we age means that we need something different than open heart surgery. With these transcatheter, these non-surgical techniques, there's no incision, no sternotomy, as shown here. There's no need for a bypass machine. It often can be done without general anesthesia. Patients are able to get out of the bed the same day, go home the next day, and the recovery involves minimal healing. So, is this transcatheter therapy competitive with surgeons, with surgery? That's what some of the people initially thought, but actually it's become a collaborative enterprise. And we have clinics where surgeons, cardiologists, nurses, anesthesiologists, imaging specialists work together to evaluate patients, to talk with them about their preferences, to come up with recommendations, and to work together. And when we do transcatheter valves, there are usually 2 interventional cardiologists and 2 surgeons scrub. So this TAVR or TAVI is a way of placing a new valve in without open heart surgery. This is the first man in the world to receive a TAVR valve. And this is a physician, Professor Crivier of Rouen, France, where they were able to do some of the very early studies in this technology. So what is this all about? Well, you've got the valve leaflets that are identical to the surgical tissue valves, but they're sewn not into a sewing ring, but into a stent, a metal scaffold. Then it's crimped onto a catheter with a balloon on the end, such that it can be inserted into an artery, pushed back to the heart, and then deployed. And this shows the deployment. We take a picture, we inflate the balloon, it pushes the valve off, it holds on to the existing valve and pushes it aside, so this is going to repeat. We pace the heart very rapidly because we don't want the valve to be implanted in the wrong place. So this is the way that a valve can be deployed, and someone goes from 1 minute having severe aortic stenosis to the next minute having a normally functioning tissue valve. So it's quite remarkable. It's so remarkable that through the efforts of many, with clinical trials that have produced the evidence base of the safety and benefits of this, transcatheter valves have grown over the last decade such that it's more than all surgical aortic valve replacements, both isolated and those combined with other surgical procedures. So it's become a very common form of valve disease. We got there because people participated in clinical trials to develop this clinical evidence to make us understand. So my hat's off to them. So it's common. Here's a husband-wife combination who they both had valves placed transcatheter-wise. One got a cow valve, one got a porcine, and they have some funny jokes about that. And they really were amazing because they helped develop for the national organization, the American College of Cardiology, educational material that helps people understand. Here's another man who participated in one of the early clinical trials we participated in fixing his mitral valve. He had a really remarkable recovery and had many good years after that, despite starting when he was only 94. And these technologies started out in being tried on people who couldn't have surgery, but now they're being used in people who could have surgery at lower risks. So the mitral clip is a technology that kind of repairs the valve. It doesn't replace it. So this is the mitral valve. This is the clip, the two doors of the mitral valve. So it brings them together such that when they close, they have a tight fit. It still opens on each side of the valve, and it significantly reduces that leakiness of the mitral valve. This is the engineered system. This part goes in the person. This is the part outside that I use to steer to the valve and place the clip, open and close it. And if I put it on and it doesn't seem to reduce the regurgitation, I can open it and move it 1 millimeter. And the person's heart is beating. So it's very different from surgery where the heart has to be stopped, then you restart it and see what you get. Here we can see immediately, do we make an impact or not? So here's an echo of another abnormal mitral valve with a little flippy thing. The valve's kind of fallen apart. Aortic valve, left ventricle, left atrium. This is the degree of mitral regurgitation before in different views, that multicolored regurgitant jet. This is when I put in a clip and left it on the valve. So that's what it looks like. This is the delivery system after we release. This is the transesophageal echo probe. While this image is X-ray, ultrasound helps us guide. And this is what we get. We only have a trivial amount of mitral regurgitation remaining after placing 2 of these clips. So these are new therapies. They have to go through rigorous studies for FDA approval. And then CMS Medicare says, well, we're going to cover it. We're going to pay for it. But there are certain conditions. We want to know more about these therapies. So we're going to require everyone who undergoes this that the hospital submits data on them about their characteristics, how the procedure went, and how they did 30 days and 1 year after, including a questionnaire that's directed at the patient to say, do you feel better with this activity or not? And this year, for the next 3 years, I'm the chairman of the steering committee of this professional society registry, where we've gathered data now on over 300,000 patients undergoing these new therapies. It's learning new things. So we make publications, we can describe indications, complications. We're learning how to improve these technologies and what people is it best for. But there's more to be learned. What is the durability of these new valves? Better, worse, or the same as surgically implanted? When is open heart surgery necessary or preferable? What can be done when a tissue valve wears out? And what about these other valves? We don't have a replacement for a mitral valve or a tricuspid valve that's yet been approved, but the investigative studies are ongoing. A lot of work going on. And don't we want to prevent this from happening? What can be done to prevent our heart valve from degenerating? The traditional risk factors don't impact on heart valves. So that's not the avenue of better lifestyles. Do they just wear out? So how many times does one of your heart valves open and close by the time you're just 70 years old? A couple thousand? Well, average heart rate of 70 beats per minute, 60 minutes, 4,000 opening and closing per hour, over 100,000 opening closing per day, over 36 million opening closings per year. And by the time you're 70, you're 2.5 billion times. Even my Subaru parts don't last that long. So it's incredibly durable, but it still wears out. There is some evidence that for aortic valve disease, where calcium gets deposited in the leaflets, that it is related to a different kind of lipid in the bloodstream that's not affected by statins. And so if we can develop new therapies to modify, to lower the lipoprotein a, maybe we can reduce the progression to severe calcific aortic stenosis. So in conclusion, this is a revolution. And it's been the entrepreneurial spirit with collaborative approaches with across the world. The engineering is amazing. So when a valve does not work, you want the best plumber. But when it's a heart valve, you better find a good heart team. And Dr. Messenger, my colleague here, is one of our leaders in this heart valve program at CU. So thank you, and I'll return things back to Judy.
Thank you, Dr. Carroll. That was great. And plumbing is critical. So our last speaker tonight before the question and answers period is Dr. Kylie Adamek, who is an instructor of medicine and in the Division of Hospital Medicine, on her way this summer to Vanderbilt to become a cardiologist, which is very exciting. Dr. Adamek graduated from medical school at Louisiana State University in New Orleans before completing her residency and chief residency at the University of Colorado. Her interests include medical education, implicit bias in medicine, and cardiovascular disease. She has ongoing research projects evaluating cardiac dysfunction in those with COVID-19, as well as use of the electronic medical record to improve outcomes in those with heart failure. Dr. Adamek will speak tonight on getting to the heart of the matter, the cardiovascular consequences of COVID-19. Take it away, Kylie.
Thanks, Judy. I will echo Drs. Carroll and Ko in saying that I am so excited to be here tonight and speak to you guys about COVID and cardiac disease, what we're seeing in the hospital. And just getting set up here. So just a quick disclosure slide that I have no financial interest or conflicts of interest with the material being presented. My agenda for today is to discuss those cardiovascular complications of COVID-19 and basically the who, what, when, where, and whys of those. So first off, I'm going to start off why this is important. What exactly I'm talking about when I say cardiac complications of COVID, how this occurs, or at least our theories on how this is occurring, who this is happening to, and when these cardiac complications are actually occurring. So we'll get to the start of why this is important. So we've all seen the numbers on COVID-19. As of February 10th, when I got my information, there were 468,000 deaths. Unfortunately, those with hypertension are about 2 times as likely to die from COVID. And I will preface that that is uncontrolled hypertension. So if you're on a medication for it, the numbers are a little bit more in your favor. But those with pre-existing cardiovascular disease are about 3 times as likely to die from COVID. And those who present with acute cardiac injury are about 10 times as likely to die from COVID. And I'll get to what acute cardiac injury actually means. So what sort of heart complications am I talking about? It may or may not seem silly to you guys, but this is actually how I've explained cardiac complications to the residents last year as a chief. I compare it to a house. So house has 5 things that I will equate to parts of the heart. So the walls, which represent the myocardium, the muscle of the heart, which is actually providing the majority of our pump function. A house also has an electric system, and the heart has a conduction system that goes along with that. A house has plumbing, so those are the arteries. That's what's supplying the heart with blood. And a house has a roof, which is represented by the pericardium of the heart, which I'll show you guys pictures of in a second. And lastly, which we just heard from Dr. Carroll, the doors, which are the heart valves and help organize blood flow. So here's a nice little picture going from left to right. We've got our pericardium. This is basically like a sac that covers the heart. And over here, we can sort of see our arteries and our veins running through this yellow fatty material right here, which are going to supply the heart with blood. And then over here, we can see that thick muscle that represents the pumping function of the heart. And then we have our heart valves here, here, and here. Unfortunately, the electrical system is not something you can really visualize, but is rather a subset of specialized cells. So as far as what complications we're talking about, if we first start with the walls, the myocardium, like I mentioned, the purpose of this is the pump function. This is the muscle of the heart. The things that can go wrong in COVID-19, first one is acute cardiac injury. This is by far the most common. It's a little bit of a garbage bag term, mainly because it only refers to an elevated blood level of troponin, which I'll get to in a second, and is not really specific about what sort of injury the heart is sustaining. About 20% of those coming in with COVID-19 will have some form of acute cardiac injury or elevated troponin. The other things that can go wrong, the muscle can actually get inflamed or irritated. And lastly, people can develop a cardiomyopathy or a weakened pump, like we talked about a little bit earlier, AKA heart failure. So this is important because those with any of these are at increased risk of death. Like I mentioned, anybody coming in with acute cardiac injury has about a 10 times higher risk of death than those just coming in without it. So getting back to that acute cardiac injury phrase, so we're looking at something called troponin. This is something that we're able to measure in the blood and is actually released by heart cells into the bloodstream when they're stressed. It's a reflection of cardiac injury, which has been revolutionary as far as being able to detect when the heart is stressed, because it is specific to the heart. There is no other organ in the body that's going to be releasing troponin. However, like I mentioned, it's not really telling us what's happening with the heart. So you may have a blocked artery, so that means the part of the heart is not actually getting blood and may be dying. You may have low oxygen overall. So somebody coming in with low oxygen levels because their lungs can't actually get enough oxygen may release troponin just because the heart is stressed. Or like I mentioned earlier, the heart muscle may actually just be really irritated and inflamed. It may be working okay, but the heart muscle itself is irritated. Or the heart may be actually working too hard and it's trying to keep up with the metabolic demand that COVID is putting on it. And here's a nice representation of that I found from our AHA-ACC paper that looks at troponin. And so these are basically all of the diagnoses that can accompany COVID that are cardiac related. And all of those may be characterized by abnormal troponin, but unfortunately it doesn't specify which one. We have to do a little bit more research into our patients whenever we're trying to figure that out. So I'll go on to number 2, which is our electric system or conduction system in the heart. So the purpose of this is essentially to signal when the heart needs to pump. So this is what we're seeing on an EKG. The things that can go wrong, essentially just abnormal heart rhythms. A lot of times this is associated with heart failure. So if somebody's pump is not working well and it's getting backed up and the heart's getting stretched, that can stretch this conduction system right here and make it prone to actually having abnormal heart rhythms. More rare, we also see some medications cause abnormal heart rhythms with COVID, specifically some of the antibiotics that we may give in concert with COVID if we suspect an additional bacterial infection. So usually the people who are experiencing abnormal heart rhythms are predisposed to an abnormal heart rhythm. And this is simply important because some of these heart rhythms can be particularly dangerous, can be deadly. And then unfortunately, you'll hear me talk about this a lot, but heart disease begets heart disease. So if you have heart failure, you may be prone to getting an abnormal heart rhythm. And that sort of feeds on itself. If you have an abnormal rhythm, that can make heart failure worse. So number 3, which is our plumbing system or our arteries of the heart, supplying the heart with blood and oxygen. While very rare, we have seen people come in with blocked arteries, which are essentially causing heart attacks. This is, I will specify that when people talk about heart attacks and they may mean very many different things. From a medical perspective, a heart attack is a blocked artery. And so that is something that can happen in COVID, also very, very rare. And this is simply important because when you do have a blocked artery, if you're not able to open it in time, part of the heart muscle may end up dying. Just a quick note on what cardiovascular disease means whenever we say that particular term. That just means narrowing of the arteries due to plaque, and that's something that happens over time and that is chronic. All right, and getting to our roof, our pericardium, this sac that holds our heart in place. Purpose of this is basically just to provide some protection from the surrounding lungs and vessels around the heart. While also rare, this can become inflamed just like the muscle can become inflamed. If this sac essentially gets swollen and inflamed, it can restrict the heart movements, which can make it hard for the heart to beat and hard for the heart to fill. And lastly, we'll talk about the doors and the valves, which Dr. Carroll talked to you guys wonderfully about a little bit ago. Purpose of these, basically just to organize blood flow through our pump system. As far as we know, there are no new valve issues associated with COVID. I'll ask Drs. Carroll and Ko after if they've experienced any new valve issues, though as far as I'm aware, and as far as I could find in the literature, we don't have any new valve issues that are associated with COVID. However, unfortunately, those with existing valve disease tend to fare much worse, probably aortic stenosis being that tightening of the aortic valve being the most common one that we see. So, are any of these heart complications unique to COVID? The short answer is no. And the much longer answer is that all of these heart problems are associated with many, many other etiologies. So cardiovascular disease, those narrowing of the arteries, can ultimately cause the pump not to function very well, can cause maybe heart failure. High blood pressure can also, over time, if it's not controlled, cause, valve issues, can cause heart failure. There are autoimmune causes. We've got House over here on the right saying it's not lupus, it's never lupus. It's certainly a rare cause, but lupus can cause some valve issues and can cause heart failure or an inflamed heart muscle. There are other viruses, so we see a lot of these issues with the flu every year as well. There are certain bacteria that cause some of these problems as well. And then lastly, and a lot of times most common, is we don't know why sometimes people will develop certain cardiac issues. So many sources of these heart problems. So getting to the how, I feel like I'm giving you guys a lot of we don't know, but really it's pretty unknown how COVID-19 is causing heart damage. There are many theories, the first one being direct viral toxicity. And what I mean by this is that the virus is actually invading the cells of the heart. And there are many ongoing studies to try and actually get tissue to look at these folks who are having, inflamed heart muscle, to get basically a piece of that muscle, or on autopsy, if unfortunately the patient ends up passing away, to actually view that virus in the cell. And then the other probably more common methods by which COVID can cause heart damage is just stress. So both stress hormones and just whole body inflammation that comes with COVID, and the demand that it's putting on the heart is probably damaging to it. And lastly, I put in oxygen supply demand mismatch. This simply means the body is asking a lot of the heart. And in the setting of COVID, where you may not be getting enough oxygen, that includes the heart, and the heart may not be getting enough oxygen. So it's demanding a lot, but it's not getting it. All right, moving into who is most likely to develop heart complications. So there's a lot of potential risks. For who I will group into two categories. The first group are those at risk for severe COVID-19. Dr. Kao mentioned it a little bit earlier. Those with old age, obesity, those are our people who are at risk of developing severe COVID. And if you are at risk for developing severe COVID, you're at risk for developing the complications that go with it, including those cardiovascular complications. They sort of go hand in hand. The second bigger group are those with pre-existing heart disease. So those maybe with really bad valve disease, with really bad hypertension, with really bad cardiovascular disease, are at risk of developing these cardiovascular complications at a higher rate than our otherwise healthy populations. So the bottom line here, like I said, heart disease begets heart disease, unfortunately. Those who have existing heart disease are going to be more likely to develop a cardiac complication whenever they get COVID. So are there any differences between men and women? There are. So in the acute cardiac injury spectrum, that goes to men. It's about a 60-40 split from what I've seen as far as percentages go. It's not, like I said, almost 20% of people who will be admitted with COVID will have some level of acute cardiac injury or troponin elevation. And this goes slightly in favor of men for numbers. Unfortunately, that pattern sort of continues with both severe COVID and death from severe COVID. So men are much more likely to develop severe COVID and death from severe COVID as well. There's a couple theories behind this. Nobody really knows exactly why. The first one is that men are more likely to have cardiovascular disease, and there tends to be a little bit more smoking among men as well. Again, heart disease begets heart disease. And then second etiology is that women may be just less susceptible to microbial infections in general. The immune systems are just built differently between men and women. And unfortunately, I'm not an immunologist, so I can't break down the etiology of that, but we just know that women, may have a tendency to do better whenever they get an infection. So what don't we know? Lots. Like I mentioned, the basis for heart complications with COVID. Thankfully, because we see a lot of these heart complications with other viruses and other etiologies, we sort of know how to treat it. And we know how to recognize it, which is what's important, because that's ultimately what's going to inform us in how we treat it. However, it does beg the question of, should these complications be treated any differently just because COVID-19 caused them? We're still treating these people with heart complications the same as those without heart complications. So currently, we're not really treating those with COVID-19 and cardiac complications any differently. And are there long-term cardiac complications? So we may have heard a phrase called COVID long haulers. So these are basically referring to people who continue to experience symptoms months after infection. More common symptoms include fatigue. And this isn't like, oh, I got 5 hours of sleep last night and I'm a little tired today. Really, really intense fatigue. People who get up, they make a cup of coffee and they have to go lie down. Shortness of breath is one of the more common symptoms that we see that lingers months after infection. Sometimes chest discomfort goes along with this, and certain levels of pain as well. Unfortunately, women tend to be affected much more than men as far as the long haulers go. They're almost 4 times as likely to have long-term symptoms. I will preface that there are many people who are a little reticent to accept that there's a true gender split, only because women tend to be a little bit more upfront about going to see their physicians if they're having long-term symptoms. So these numbers that we're seeing, where women are 4 times as more likely to have long-term symptoms as men, come from basically doctors' offices who are keeping track of those who are coming in with COVID symptoms after infection. So I think time will tell us if there's a true gender split, but for now, we are seeing definitely more women than men come into the office. So I will end with, what can we do about this? So if you have the opportunity to, get the vaccine. If you have any hesitancy, please talk to your physician. If you don't have a primary care doctor, establish with one. And get an annual exam. Like we were talking about, a lot of these pre-existing heart conditions can be detected just with auscultation, with listening to the heart, as well as annual labs and examinations. Tell your doctor if you have any sort of unusual chest discomfort, tightness, shortness of breath, especially with exertion that seems out of the usual for you. And then if you've had COVID, don't be afraid to speak up about any sort of lingering symptoms. Here are my sources. These are the literature items that I gained a lot of my information from. And I will end with our question session. I will turn it over to Judy first, though. Thanks, everyone.
Thank you all 3 for excellent talks. I think they were terrific, and we had quite a lot of interest. So I'm going to launch right into the questions and answers and ask Dr. Kao, who answered these questions, some of the questions online, but I think talking about some of these things will be very helpful. Are there any data showing a list of possible reasons why the month, day of the week, and time of day of hospitalization shows such differences in death rate? You're muted, Dave.
Yep. Yes, this has been looked at quite a bit. I'll start with the seasonal or monthly thing. That seems to be driven a lot by temperature. There are a few sources of evidence for that. One is that my group did an analysis adjusting for temperature, and it seemed that the effective temperature was stronger than the effect of the month. But in addition to that, if you look in the Northern Hemisphere, the peak is in January of mortality. And if you look in the Southern Hemisphere, the peak is in July. So obviously that would track with the lowest average temperature of the year. And there's less variation in equatorial regions than there is in sort of more high latitude regions. So I think it's probably that. We looked at air pollution, didn't really seem to be that, or humidity. We looked at that as well. So right now that one seems to be temperature so far as we can tell. And there's reasons why we would think that would be true. For day of the week, that seems to be a staffing thing. There have been some other studies that looked at weekend effect when there's a lack of staffing there, which seem to suggest worse outcomes. So you can imagine if you are admitted Monday, you have 5 days of full staffing, to get treatment going. That's, it's sort of intuitive in some ways, but there is some data to support that. And I think there is something to that for the time of day as well. There are biologic variations throughout the day, but I think it's also a staffing thing where if you come in first thing in the morning, your first 12 hours, you have full staffing and all the testing resources, things get done quickly. If you come in at night, a lot of times you languish overnight until the early morning. So, I think that is part of it. I don't know that it's all of it. Interestingly, people have asked about residents, about the effect of house staff. There probably is some effect of house staff on seasonal variation if you compare academic and non-academic places, but that one's still poorly defined.
Thank you. Dr. Carroll, is University of Colorado, UC Health, actually doing TAVR to replace bicuspid aortic valves on younger patients now? Do you have data on how long this intervention lasts? Good question.
So first of all, when you're born, about several percent of births involve aortic valve that's different. Rather than 3 cusps or doors, they have 2. So it's called bicuspid. And the bicuspid valve doesn't last as long. Sometimes it fails when people are children. Sometimes it lasts much longer and fails when they're adults. So it is a fairly common congenital heart abnormality that can lead to dysfunction of the valve. And so it's a very good question, can TAVR be done? The short answer is yes, although there are some things still to be learned. First of all, a significant proportion of people with bicuspid valves also have an abnormal aorta, the big vessel above the aortic valve, called an aneurysm. And TAVR would not take care of that. And that's where surgery to both replace the valve and replace the ascending aorta needs to be done in those patients. Secondly, the bicuspid valves can be even more extensively calcified and thickened. And so there was a real concern about whether TAVR valves would work in that setting. And the patients with bicuspid valves were excluded from the early TAVR studies. So we have learned a lot since then. And so it's certainly being used commonly in people who are particularly older, who need a new aortic valve. And there's no difference in durability as much as we know about durability in TAVR, because it's not been around for decades and decades. So those are the key things. In younger patients with bicuspids, in general, a tissue valve, be it surgically implanted or transcatheter implanted, is problematic because the younger you are, the more rapidly a tissue valve degenerates. That's an unfortunate fact of life. So I think that's an issue that particularly impacts people with bicuspid valves because they tend to be younger when they need a valve.
Thank you. Dr. Adamek, do you have any data related to age groups with cardiovascular disease symptoms related to COVID-19 infection?
Oh gosh, that's a good question. Unfortunately, I think the cardiovascular consequences of COVID are such that the epidemiologic studies that we have on them are not stratifying by men and women right now. We're still trying to learn about why people are getting these complications and what we can do to best treat them. I could not, for the life of me, find anything past the acute cardiac injury, which does tend to favor men a little bit more than women. Like I said, maybe 60% versus 40% being women. But beyond that, I couldn't find anything for like pericarditis, which is that inflammation of the surrounding sac that holds the heart in place, or myocarditis, which is the inflammation of the muscle.
Dr. Kao, how well do you think X serves precision medicine?
I think it depends on where you are. In a lot of places, people curse Epic, Vanderbilt being one of them, by the way. But I would say at UC Health, we have just a tremendous group of folks on the IT side, and they've really been pushing the boundaries of what Epic or EHRs can do in general. In our hands, I think we've been able to do a lot of really interesting predictive modeling, a lot of what we call decision support or automated recommendations within the system target certain interventions based on genes, based on other things. So it's an indispensable tool for me and for us in doing this, but it really depends on the computer guys that you have behind it.
Dr. Carroll, what is the time span for a bovine valve my husband had placed in 2014, and how long may it last? He was age 64 when he had it placed. They were told about 15 years, which would make him in his 80s, and then up against the success of TAVR for the elderly.
Well, number one, we don't think there's a difference between bovine and porcine leaflets in terms of durability. Secondly, it's impossible to predict how long a tissue valve will last in an individual. Other than age, we really don't know what other patient-specific factors modify the durability versus the degenerative process in people. And that's an important area for research. So if you look at a whole series, say of 100 people with a tissue valve, you'll see some early failures, some averaging what's been quoted for that age group as the average longevity, be it 10, 15 years, and some people where it never degenerates. So it's a spectrum. So the good news is that surgically implanted tissue valves, when they do degenerate, especially as we're getting into older age groups where having repeat surgery is higher risk, the TAVR procedure has been refined for putting a new TAVR valve inside the surgical valve. It's called valve-in-valve. It's FDA approved based on data we and others have collected on it, and it offers a real good option for, say, the 75, 80-year-old who had a tissue valve placed when they were 60 and they were, robust, not frail, to have a way of getting a new valve that will probably last the rest of their life and not have to undergo repeat surgery, which is obviously a higher risk and more technically complex in some people than the initial surgery.
Thank you. Here's a question that all three of you may want to address. Are there any differences in how cardiovascular disease is currently diagnosed in females? Is there anything new in terms of this? This is a big area of interest for those of us who study sex differences. Kylie, do you want to start?
Oh gosh, not a cardiologist yet. As far as the thing that I always tell people are that women can obviously present, at least in the acute setting when they're coming into the hospital with complaints of chest pain or shortness of breath. So women may actually have symptoms that are very, very different than men. So I try and impart that a lot, that, sometimes women, if they're having a heart attack, will have, stomach pain or maybe just nausea. I had somebody the other night where it was only nausea, and we ended up getting an EKG, and it was concerning for a heart attack. That being said, it's probably a little bit more different whenever we're talking about cardiovascular disease from a long-term, so from a chronic perspective. I'll let Drs. Carroll or Ko answer that. I know there's some differences in calcium scores that can help, but as far as the actual diagnosis goes, I'll let them take that.
So diagnostically, most of the testing has similar specificity and sensitivity, independent of one's gender. Therapeutically, there are more differences between the two. In the early days of TAVR, despite degenerative aortic stenosis being more prevalent in women, partly, if not majorly, because they tend to live longer and therefore have more opportunity to have the valve degenerate, we couldn't treat as many women because the size of the artery through which we put the delivery system in women is on average smaller. And the initial generation of this technology had big tubes, and that really affected things. Fortunately, the miniaturization of the technology has now allowed women to be treated, and actually statistically they have better results from TAVR than males. But diagnostically, I can't offhand think of any major new developments that are relevant to valvular heart disease or coronary disease for that matter. David, do you have any other insights?
Yeah, the one that I can think of is stress testing. Treadmill only stress testing in women is not very specific, or put another way, there are a lot of false positives there. Depending on how militant you are about that sort of thing, there are some who would say you should always get some kind of pictures or imaging with a stress test in women. And to be honest, that's what I often do, just because the false positive rate is extremely high. So that's the only thing I can think of, though. There are other interventions, like I said, that like Dr. Carroll said, that have additional considerations. An important one has been LVAD, where there are a whole lot of differences between men and women there in terms of outcomes. Women tend to do worse with them. Up until the very recent devices, when women tended to not be offered them as much and then turn them down more when they were offered them for a number of reasons. I would agree that the more significant differences are on the therapeutic side and how to approach that, just because the considerations are much different in whether it's anatomy or other preferences too. But that's all I can really think of.
Women do tend to be less diagnosed, or diagnosed less often with cardiovascular disease still,
Yeah.
and more often have their symptoms ascribed to psychiatric causes still, but it's getting better. I think physicians now recognize women can get heart disease, do get heart disease more often. Can or should non-obese women under 60 who have a hereditary mild to moderate atherosclerosis and benign PVCs, premature ventricular contractions, get one of the COVID vaccines? I think the question is, should they get it because of health considerations preferentially, or maybe before others?
I think that the real question there is it symptomatic atherosclerosis or not? Because the data is pretty clearly that symptomatic coronary artery disease is the big risk factor, as well as heart failure, of course, and then it gets a little softer underneath that. So as far as I know right now, what qualifies as a higher risk comorbidity, I don't believe that does. Maybe Kylie or John, if you happen to know differently, obviously let me know. But I don't think that falls into that category for a sort of prioritized vaccine. I don't think it does.
I have another question. How important is it to know our calcium score for heart health? And that's been very controversial over time, so I'm hoping that we can address that. Who would like to say?
Well, I think the data are pretty clear that number one, calcium is a surrogate for the underlying pathological process we're worried about, atherosclerosis. And therefore, its detection, its quantification does have a usefulness that for screening purposes. Now, it doesn't tell you whether or not a coronary artery is significantly blocked or not. So it doesn't have the physiologic importance. But the CAT scan technology that really allows the calcium scoring has advanced such that you can get angiographic CT. So you can get both the calcium score, but then assess the lumen, the size of the artery, and the degree of blockages. And that has come along in another way, in that they're able to look at the what we call flow reserve down a coronary artery and using a computational modeling. And so CT assessment of coronary artery disease is developing in a variety of different directions. It started with calcium score, but it's really progressed such that some of the times you don't have to undergo the invasive coronary catheter-based angiography because CT is that good now.
I would add to that or just so it's clear that there are coronary calcium CTs and there are CT angiograms on which you can also get calcium scores. And I only bring up that difference because there are health fairs or trailers or whatever where you can get a coronary calcium score, and you won't be able to get the angiogram part of it with those scanners. So it's not as though you can get those everywhere. At UC Health, you can certainly get those, but just to set expectations around that.
Final question: can a mechanical valve be implanted using the TAVR method?
I wish, but the short answer is no. But maybe in 10 years we will. Mechanical valves remain an important option, especially if one is younger and needs a new valve. Why is that? It's because they don't typically wear out. Yes, there can be clot forming on, you have to take a blood thinner with a mechanical valve, but it has a durability that surpasses tissue valves. And as I've mentioned, in younger people, tissue valves degenerate more rapidly. But to devise a valve that you can deliver that's a mechanical valve, deliver it through an artery the way we do, it's going to take another leap of engineering skills and technology that we don't have presently. So all the TAVR valves are tissue valves.
That was great. Well, thank you, all three of you, for your excellent talks and excellent handling and answers to the good questions that were posed to us. And we really appreciate it. Please join us for our next Let's Talk on April 28th on the topic of infectious diseases. Registration is open and look at our website, cwhr.org. Thanks, everyone. Take care.
Good evening. Bye-bye.
Thank you, everyone.
Stay safe.
Bye.